Good afternoon, ladies and gentlemen. I'm Dr. Nishant Sharma. Welcome back to another episode of this virtual series of discussion on arthritis in India, a nationwide dialogue. This series is a joint initiative by Voice of Healthcare and Pfizer, where we talk about the different spaces of arthritis and its care in India. Today, we will be discussing about what is arthritis. We'll try to understand the different forms of arthritis, the different types of arthritis that are prevalent in India. We'll talk about management strategies through orthopedic surgeons, and we'll try to understand about the prevalence, some public health initiatives that there are, and some measures of preventions right from the experts. So without further ado, allow me to welcome my set panel of experts today, which is Dr. Prakash K. George, consultant orthopedic, joint replacement and sports medicine surgeon, Daya General Hospital, Kerala. Good afternoon, Dr. Prakash. Thank you for joining us. Thank you. We'll be having Dr. Mohamed Shabaz Sherif, Senior Resident, Sree Gokulam Medical College and Research Foundation, Trivandrum, and Dr. Kunda Sridhar, Orthopedic Surgeon at Kunda Hospital, Vijayawada, joining us shortly, who will be part of this conversation as well. So, Dr. Prakash, to set the tone of this discussion, let's start by understanding arthritis. So, please provide an overview of what is arthritis and what are the different types of arthritis that are prevalent in India, according to your clinical experience, please.
Yeah, good afternoon all. So arthritis, as we all know, is the swelling and inflammation of one or more joints. So the main symptoms which include pain and swelling of the joint. It typically worsens with age. Normally, as we progress the age, the pain also worsens. The most common type of arthritis include osteoarthritis, that is because of the friction between the bones. Another type is rheumatoid arthritis, that is because of an autoimmune pathology,
Right.
gout or arthritis, which is due to increased uric acid, and other rare forms of arthritis. Most commonly is because of these three. The most common in clinical practice, as we all see, is osteoarthritis. That is because of the wear and tear of the joint due to increasing age. There are several risk factors for arthritis, which include obesity, low movement, and lack of exercise, etc. And whereas rheumatoid arthritis is a autoimmune pathology, so that is because of your the inflammation against your own joint by your own body. So that is a different
Right.
pathology. Yeah.
Right. Thank you. Thank you, Dr. Prakash, for setting a good tone of this conversation. So, on a clinical observance, how do patients present with arthritis? What are some common signs and symptoms that you would want to educate our audience about?
So the most common form of arthritis that we see is knee arthritis, the knee joint. The patient comes to the OPD with pain in the knee. There will be swelling in the knee. There will be difficulty in movement of the knee. Patient will tell, doc, about 2 weeks ago I was fine. Now the pain is slowly increasing to a point that it is difficult to bend the knee and walk on the knee. That is the most common presentation in our OPD.
Okay.
So such a
And when we
patient
talk about, yes, please, please.
Such a patient usually goes to a family doctor and takes some medicines and get reduces the pain. But after some time, the pain becomes intolerable. That is mostly when they come to an orthopedic surgeon.
Right. And let's say that a patient walks into your clinic. What are the different steps that involve in the diagnosis that is made that this patient particularly has arthritis?
So the diagnosis, it starts basically from the moment the patient steps in the room. Once they come into the room, we can see how they walk, how they carry their leg. From that point onwards, the diagnosis starts.
Okay.
So first we examine the patient, first by visual examination, then by clinical examination, and as per the history, we ask for some investigations as the next step. So we take a detailed history along with a visual examination and a physical examination. So the visual exam, these are of different types. History, we ask how long the pain has been. Is it been going up and down, or is it being constant? Is it increasing over the duration of the time? Is there any early morning stiffness? That is, when you wake up in the morning, are your joints stiff? All those questions we ask during the history. In the visual examination, we make the patient walk and observe the knees. Is there any bend in the knee? Is the knee bending? Is there any bending of the knee? Is the knee movement normal, or are they limping on that leg? Are they able to walk with a normal stance? All these things we see in a visual examination. Then we take the patient on the bed, do a clinical examination, and after that we ask for some investigation. Most commonly we ask for an X-rays.
Okay. Right. Thank you, Dr. Prakash. So, in this sense, how do you feel early diagnosis impacts the overall treatment outcome for any patient with arthritis?
So let's take the example for knee itself. When a patient comes to us, he may be in any of the stages of arthritis. In early stage of arthritis, the wear and tear of the cartilage has just started. At this point of time, if we intervene with proper exercises, weight reduction, and supplementation, we can delay the onset of arthritis or delay the progression of arthritis to be better. And patient can prolong the life of his own joint to a larger extent. Second type of patients come when it is like moderate arthritis. At that point itself, there will be some cartilage left in the joint. Still, if you take care of the body weight, if you do the exercises regularly, if you take the supplements regularly, we can delay or even prevent a surgery. The third type of patients present very late in the OPD, all the cartilage will be gone and the bone will be touching on the bone in an X-ray. When we take a standing X-ray, if the bone is touching on the bone, then those patients have very less chance that they can get away without a surgery. At some point of time, they will have to either decrease their walking or change their lifestyle, or they have to go in for a surgery to get the mobility back.
Right. And like we are talking about the different types of treatments that are available depending on what kind of grade is the arthritis at. Let's talk about managing arthritis. So let's talk about the management strategies that you recommend and you deploy. So suggest some effective strategies for maintaining, let's say, both medical, surgical, or the lifestyle modifications that you as a practitioner deploy for arthritic patients.
So first we have to diagnose which type of arthritis it is. Is it an osteoarthritis, which is due to wear and tear of the joint due to age, or is it a rheumatoid arthritis, which is a wear and tear of the joint because of an autoimmune pathology, or is it due to uric acid? If it is due to uric acid, we have to start with medicines to reduce the uric acid levels and along with anti-inflammatory medications.
Good afternoon,
If it
everyone.
is due to
Sorry
a
for the late entry.
rheumatoid arthritis, then we have to start disease modifying drugs. After consultation with a rheumatologist, we start along with the other medications. But if it is pure osteoarthritis, then we normally start initially with anti-inflammatory medicines to bring down the pain and swelling, to increase the movement, and start off with the exercises so that they can get back to movement. Now, management of arthritis is in different levels. First, we start off the medicines, as I told you. Second comes the lifestyle changes, which include you have to reduce your squatting or sitting on the floor. You have to reduce your climbing in the stairs. You have to reduce going up and down hill. You have to reduce your weight. That is a major factor in the development of arthritis. Along with that, you have to do regular physiotherapy or exercises to improve your muscle strength so that the load on the bones is less and the progression of arthritis is reduced. These are all non-surgical treatments of arthritis. If any of these fail, all of these fail, then we go into surgical or interventional management.
Right. Thank you, Dr. Prakash. Welcome, Dr. Shabaz Sherif. Good afternoon.
So, good afternoon. I'm sorry for the late entry. I was in a case. I just got out and I was getting. Hi.
No problem, Dr. Shabaz. We have Dr. Prashant with us as the co-panelist for this arthritic awareness discussion that we're doing. And we have already
Dr. Prashant.
discussed with Dr. Prakash about what is
Prakash.
arthritis, what are the different prevalent types of arthritis that we see, and we have talked about the symptoms, and we've talked about how diagnosis and early diagnosis helps. We were just discussing about strategies for managing arthritis. So we'll start with you based on the same. So suggest some effective strategies for managing arthritis, both medical and lifestyle change approaches that you deploy as a practitioner, please.
With the kind of patients I have, mostly elderly with obese people. So what I suggest is before we get into a surgical management, we need to control their lifestyle, because after the surgery, we need them to have a better outcome of the surgery. So, if at all it's the surgery is the only option we have. So, I start off with weight loss programs, the diet, and then start extensive exercises so that they can maintain a good muscle tone and muscle strength. From then on, we'll suggest surgery. After surgery, again, extensive physiotherapy, exercises, diet control, so that whatever we do, if we are going on for a surgery, the implant has to last long. For that, basically, we have to reduce their weight, we have to increase their muscle tone, their regular lifestyle has to change. So I advise them that what has happened before this point of time that you've come to consultation with me, before that point of time, whatever has happened is going to change. From now on, things are going to be different. Your entire lifestyle, whatever you have followed, will change. So your diet will change, your lifestyle will change, your exercise routines will change. Your primary concern is to maintain a good muscle tone on a controllable, lean, or what do you call it? A proportionate body.
Right.
It doesn't matter if you are bulky or not. The bulk has to be muscle. The bulk cannot be fat, and the fat cannot overtake your muscle load. So we'll make them exercise more, increase the muscle load, so that whatever load they have, some people cannot reduce their weight beyond a limit. So my focus will be on increasing their muscle load, so that they can they can take the load of the upper body weight. So focus is on diet, primarily on diet, weight loss, and increased exercise. Increased exercise. That is what I do. Not just walking, not just running, not just burning fat, not just cardio. Muscle strengthening, muscle increasing, muscle strengthening exercises. This is the primary focus of my plan.
Thank you, Dr. Shabaz, for discussing that. Dr. Prakash, my next question will be for you. Any recent advancements or innovative treatments that have come up that help clinicians combat arthritis better, and you recommend exploring?
So there have been a lot of innovations in the field of arthritis management, mostly in the surgical field. Earlier implants used to last only for 5-10 years. At that rate, we only used to do knee replacement surgeries for older patients who are like 70, 80 years. Now, with the advent of newer implants, there is a 90% chance that the implants will last for about 20-25 years in the world, if done properly and with proper indications. So there has been a lot of advance in the material of the implant, and also the technology has improved with respect to how we do the knee replacement. Nowadays, the earlier form of knee replacement used to be mechanical, when we use alignment rods and all to check x-rays to check the alignment of the leg has been corrected or not. Nowadays, after that, navigation came into picture. It is computer assisted. So the computer will tell us that this is not straight, this is so much degree bent, we have to correct that much more. That was the second generation. Now we are into the next generation of robotic knee replacement surgery, in which we can take assistance of the robot itself to get the cuts perfect and to get the alignment proper. It is a new technology. It is we are just going into the technology. We have to still see the long-term outcomes of the robotic technology, but it is a technology is moving forward, and we have to move forward along with the innovations.
Right. Thank you, Dr. Prakash. My next question will be for Dr. Shabaz. As we know, and both of you panelists have also enumerated it well, that arthritis, for specifically for osteoarthritis, affects the senile population, the old age population. So, how do you feel, Dr. Shabaz, that this particular arthritis affects the population? And let's talk about the psychosocial effect that arthritis has on such patients. Please.
We are basically mobile creatures. We need our mobility to feel good. So if we are not, if our limbs and our mobility is being restricted, obviously sorry.
Yes, sir. Please continue.
I'm back. I'm sorry. So
No
basically,
problem.
if our mobility is being restricted, our entire what do you call it? Mental status, happy living is all affected. So for whatever reason, am I audible?
Yes, sir. Please.
So for whatever reason, our the main motto most orthopedicians have taught me, my boss has taught me, is mobility is life. So if the mobility is hindered or restricted by any means, it is not going to be a good life. It's not going to be a happy life. So our main aim is to maintain that mobility. That is the reason why we have these surgeries, we have these implants, we have these improving technologies and all that. So the primary concern with our population is that we do not give much importance to exercise. We do not give too much importance to a balanced diet, not just diet, balanced diet. We assume that it's okay to have once we cross a particular age limit, it's okay. It's okay. We do not need to do the social stigma of having to do exercises. People saying that it's not normal for us to do. Most of the communities prefer not to do exercises. In the other way, if communities are promoted into saying that this is a normal, as far as I'm concerned, in Kerala, people are not interested in doing exercises. They think it's not a normal thing to do, but the normal thing is to do exercise. It's not to work, it's to do exercise. If you have the strength, let's say, if you have the strength to do a 10 kg work and your work is only 5 kg, the 5 kg remaining strength that you have is a bonus. This is what you have to educate the people. The more strength you have, the less effort you have to put on your regular activities. Your activities will seem like a easy task for you. This, if you promote these in the people, if you make them understand that you can have your diet, it's all good. But if you have your diet, make sure you do an extra exercise to burn out those. You have to tell them which kind of food is required for you, what is required for you. Carbohydrates are just fuel, proteins are good for you. Focus on more vegetarian diet, which is also good for your bowel movements. If you educate them in multi levels, I think this can be rooted out from early age, early times, and we can eventually age related wear and tear will catch up to us. But if with this catching up with this education, maybe we can make this much feasible, much more appropriate for the common people. Not
Right.
just depending on the surgery, modifying their lifestyles too.
Right. Thank you, Dr. Shabaz. So, in continuation to how Dr. Shabaz started the conversation about patient education and early awareness, Dr. Prakash, my next point of discussion with you would be any support systems or resources that are available to help individuals with arthritis lead a fulfilling life that you're aware of.
So the support system is usually their relatives. That is the most important motivating factor in our community. If one of their relatives or their friends have underwent a surgery like knee replacement and is successful, then they are really motivated to get the surgery done, to get back their movement, to lead a successful life in the future. But if some of the relatives have had a bad experience, then that is a deterring factor for the same patient. So, as far as I am concerned, friends and family are the most important support system for a patient. Second thing is our own patients. If we can show them to our patients in the wards, talk with them, tell them about their experience during surgery, after surgery, that gives a good motivation for them to undergo the surgery. Because the main thing is that they are scared of the surgery. The inhibition of them to undergo a surgery is the uncertainty about the future after surgery. How are they going to affect, how their lives are going to get affected? Is it too painful? Is the procedure successful? Are they able to walk after surgery or will they be bedridden? All these are their inherent fears. So we have to deal with their fears to educate them that this is the way forward. These are people who have undergone surgery. You talk to them, you ask them your queries, and they will give the patient more confidence to undergo surgery. And also, if the patient is opting for a non-surgical treatment, also, if the patient is properly educated that okay, the weight has to come down, the muscle power has to improve, then only the things we are going to improve. There is no other way out. We have to educate the patient and tell them that these are the way to avoid a surgery, to prolong your own knee. If we educate them, then that is a very good motivating factor. Problem is that they will go to one doctor, take some medicines, not working. They go to a second doctor, takes another set of medicines, not working. They go to a third doctor, and they keep on shifting rather than solving the problem dead ahead. So we have to educate them that this is a disease that is going to progress in your life. It's going to have its ups and downs. You have to stay focused with your goals or your treatment modalities, and it will become successful at some point of time. You have to give them hope, both in
Right.
non-surgical as well as surgical options.
Right. Thank you, Dr. Prakash. Uh, Dr. Shabaz, my next question will be for you, where we'll talk about, as we know that combating arthritis is requires a multidisciplinary approach, a collaborative partnership between different healthcare professionals, be it occupational therapists, be it rheumatologists, surgeons, spinal surgeons. How do you feel that this impacts the overall healthcare delivery, and how is it important, this collaborative effort?
It is supposed to be very effective. It is a very focused approach that what you proposed right now is the right way to do things. We have to have, if it's a rheumatoid osteoarthritis, we have to have a consultation and a proper follow from a rheumatologist. The role of an orthopedician comes only where he is going to replace the surgery, replace the particular knee or whichever joint it is, shoulder, knee, the joint he is going to. That is the only role of an orthopedician, as far as I'm for honest reasons. Only surgical reasons or what do you call it? Replacement reasons. That is where the absolute role of an orthopedician comes. The rest of it is taken care of by different facilities. The medical, if the patient has a medical condition, that is taken by the general medicine. The physiotherapy that I'm talking is taken care of by the physiotherapist. The patient is a rheumatoid patient, it's taken by the rheumatologist. And every other aspect of this patient is controlled and taken care of. The psychological impact, the impact, psychosocial impacts, most probably sometimes it's taken by a psychologist, a psychiatrist, whoever it is. So our role is primarily and starts and begins with the replacement. Everything else is what we're doing is multitasking. So I prefer to have all these systems, all these super specialities given their appropriate importance, and we have a multitasking unit. So we all help each other. We need to know each other's importance equally. We are all equally important. So surgery is not the end of the treatment; it is the beginning of the treatment. Identifying the need for the surgery is another section. What diseases lay ahead of the patient or lay behind the patient, to identify that is a different area. Where we come in is where we provide a solution to the completely destroyed or destroying joint. That is all we do. The rest, managements above and below, has to be done by other multidisciplinary specialities, and their importance is unsaid. It's not focused properly in our system of medicine. We have to have a multidisciplinary approach to this. Everyone has to chip in. Everyone has to take care of it. We can't be the only ones responsible for this arthritic condition or the treatment of it. Even after we have our, let's, like you said, rheumatoid patient, even after we had surgery, we replace it. Is the treatment over? It's not. It's not. The rheumatoid is still there. It is a condition. It can get worsened, or it can get the much worse than it used to be previously. So there, the rheumatologist is the final hero. He has to take care of the rest of it. So we have to identify that our each disciplinary action's role, and they have to perform accordingly. That will be the best result for the patient, as far as I'm concerned.
Right. So obviously, it's about the healthcare delivery. It's about patient satisfaction. Is, I think, what you're trying to say. Thank you, Dr. Shabaz. Moving over to the patient education and the awareness for arthritis through this medium of this arthritic awareness virtual campaign. Any common myths or misconceptions that you, as clinical practitioners, have seen around arthritis or bone health? We'll start with Dr. Prakash, please.
So the common misconceptions are, most commonly, arthritis is something that is not to be tackled head on. They just say that it is a part of life. You are old enough. You are now 60, 70. Now the body is going to pain. You have to stop your movement. Sit at home. That is the first misconception. As with current technology, with current surgical modalities, you can get back into your life, regain your mobility much easier and much faster. So people don't know that. Second misconception is that if you do a knee replacement surgery or if you undergo a surgery, you will be bound to your home. It will last only for 5 to 10 years. That is the second misconception. Now, as I told previously, now with newer joints, we can easily go up to 20 years, in maybe 25 years also, if they take care of their body. Third misconception is if you do a surgery, you cannot sit on the floor, you cannot sit on the ground. You have to sit on a chair always for the rest of your life. That is also not true. You can sit on the floor, you can sit on the Indian toilet also. But problem is that the life of the joint will be affected. That is why the surgeons advise against it, not because you cannot do it. Another misconception is you can only walk slowly, you can never run. There are people who have gone on marathons, Mumbai marathon with a knee replacement surgery. But again, the life of the joint will be affected. It's not a matter of whether you can do it or not. You can do it, but it will affect the life of the joint. That is why the doctor advises against it. Then, as far as going to an orthopedician is concerned, uh, they are scared that the surgeon will advise a knee replacement surgery and no other option. So they will go to another doctor who can give another option. So if a joint is completely destroyed, then there is not much role of this injections and all those things.
Hmm.
So, but people will go to different doctors to try out different options, different modalities of medicine, homeopathy, Ayurveda, etc., to anyway avoid the surgery. But they have to see the problem. If the disease requires a surgical treatment, then there is no point of wasting time and years of life. That is the most important thing. You could have done the surgery maybe 5 years earlier, and you could have gone to 5 different places. You could have attended different meetings which you couldn't go to. You could have met your family who is staying abroad. All those things, the life, the quality of life would have been much better. Because of these misconceptions, people are scared of doing a surgery.
Right. Thank you, Dr. Prakash, for sharing your valuable insights there. Dr. Shabaz, similar question to you. The common myths and misconceptions and misinformations that you see and would want to bust through this awareness campaign, please.
Most of the patients I come across with, their main idea is no matter what you do in the surgery, the pain is going to remain. That is the thing. The understanding of what is going to happen is what they need. We need to educate them that there are two different types of pains that is associated with this. Right now, whatever they are facing, the pain is mostly intra-articular. It's in the bones. It's because the bone is grinding with each other. That is the pain that we are going to alleviate. We are going to remove that pain by giving a surface to it. That is not going to the bone is not going to get eroded anymore, and there's no going that intra-articular pain is going to be. But the pain that is associated with the incisions, the approaches that we make, it is going to last for a while. People after the surgery, they expect that it's going to be like wearing a new shoes. Okay, the shoes is going to fit in right away. There's no pain. There's nothing. You're going to run. But no, the idea is to give you a long-term result. The result is supposed to last for a longer term, not an immediate result. The immediate effects might be a bit squeamish, and it's going to be a bit painful. But if we can push through it, the results we expect are to last long. It's in the count of years, 15, 10 years and all that. That is what our results are. So in that span of 10, 15 years, this a month or a two should not take prevalence over that. You should make the people understand that you're going to have pain, you're going to have discomfort, you're having a new implant in your body, new substance in it. It's like wearing a new shirt. If it's just a tight new shirt, unless it fits into your body, it is going to be uncomfortable for you. So if that's the reason, that's the explanation for a shirt. Imagine an implant being put inside your body. So you will have discomfort. You are going to expect discomfort. Make them expect a discomfort, pain, but educate them that this discomfort is not going to last. It is an adjustment process. You are going to adjust to it. In the coming years, you're going to have a beautiful life. You're going to have a free joint. You're going to have a healthy lifestyle. This is what you're going to focus on. So the initial, they expect everything to go peachy. I mean, good right after the surgery. That is not going to happen. That is what you're going to tell them. And they expect another thing. Once my patients come and ask me, most of the patients come and ask me, so you cut out the bone. What they think is replacing the joint is cutting out the bone. No, it's not cutting out the bone. It's cleaning off the uneven surfaces. We just carpenters. We're just cleaning off the uneven surfaces, creating a clean surface, and then keeping something like a cap on top of it, so that the bones are not exposed again, so that they don't come in contact again. It's like wearing a covering surface. We're not chopping off ends of the bone. We're just cleaning off the uneven surfaces that the arthritis has caused, and then we're putting a cap-like surface on it and recreating a joint which you would never have otherwise, because it's already eroded. So we are recreating a joint that has previously been eroded and giving you a better lifestyle. So there's no options left for them. Nothing's gonna. And then there's these medications. There's a lot of medication saying that you eat this, your joint is gonna come back up. That is not possible. No medicine, nothing has ever been created that can regrow your lost cartilage and lost tissues within the joint, within the knee joint. What is the eroded is always going to be eroded. It's not unless you intervene into it and do something about it, or control the erosion before it has reached a critical point. There is nothing you can do about it. No medicine can help you with this. This is what people think. Okay, I'll try Ayurveda, I'll try other medications, I'll try supplements, and then we'll see. No, it's not going to work. There's nothing that can replace your eroded, misformed, the deformed, and the shape of the bone has deformed. It will not magically grow back into your previous glory. This is what people have to understand. There are places where you have to intervene, and this intervention is for your own good. And there's no medication, no matter who tells you, externally, internally, intra-articularly, there is no medication that can regrow your bone into the previous glory. Whatever has eroded will erode. It is up to you to decide whether you want to live with this deformity and this pain, or try and attempt at surgery that has been perfected through years to make your life and your lifestyle better. That is your choice.
Right. Thank you, Dr. Shabaz. Very, very insightful answer there. Dr. Prakash, my next question will be talking about the different prevalences that we see in India. So, as we know that there is a variation in the socio-economic prevalence, there is a variation between rural-urban's prevalence of arthritis. So, I'd like to understand your views on the different kind of variations that we see in terms of arthritis in India, please.
So, as far as the urban and rural populations go, mostly the urban population people come to us early because of the availability of the hospitals or the medical facilities. But problem is that they are having a busy lifestyle. When we tell that they have to take the time out to undergo this exercise therapy, controlling the diet, most of them are not so keen on doing that because of their busy lifestyle. Some of them do, yeah. But it is more difficult to treat an urban population as far as the exercise and all those things are concerned. Those are the main concerns with an urban population. With respect to a rural population, they are more receptive to exercises and all, because they have been working their entire life. They are going to the field. They are usually farmers or workers. But problem is that their access to medical field is less, and also when early intervention is required to delay the delay the progress of arthritis, most of them present very late to us with severely bent knees, and the joint has already been gone. So at that stage, there is very little that we can do to recreate to regrow the normal knee. So at that time, when we offer them a surgical method, but they are not so keen to undergo that also. That is the main problem with rural and urban as far as I have seen.
Okay. Thank you, Dr. Prakash. Dr. Shabaz, your opinions on these notable differences and variations that we see in prevalence of arthritis, please.
Because in the urban areas, the people are more educated, and I mean, in the cities and all that, people are more educated, and then they're more prone towards exercise. People, you see a lot of people who are, more accepting towards exercises, good lifestyles, good dietary habits. I'm not saying in the villages and the rural areas there are a lot of mispractices. Most of the time, what I see is the farmers and the working class people are the ones who are healthier than the ones in the city, because we are having a very sedentary most of the times. If you minus the gym and the exercise patterns out of our life, we have a very sedentary lifestyle, we have a very comfortable lifestyle. But if it's in the village areas, they are actually working class people, they have their muscles toned and all, and they are very stronger than us, most probably, in the city, the ones who are dwelling in the cities. So yes, more education has to go to the people in the rural areas, where who they're told that there's a condition coming up like this in the future, and you need to take better care of your bone, better control of your diet, and better exercises. And before it get worse, mainly you have to educate them on the fact that you do not have to tolerate this, you do not have to live with this deformity for the rest of your life, like your ancestors have lived, like your grandmothers and your grandfathers have adjusted to the deformity, thinking that yeah, it's all done, it's nothing, there's nothing more to be done, this it's going to be like this from the rest of. You have to tell them that's not what it is right now. The things have changed, the times have changed, there are things that we can do to make your life better for the future, coming future. That is what I think the rural area people needs. The urban people need to be taught that this lifestyle and these exercises are not a momentary thing. It has to be a regular follow, a regular thing. It does not come when it cannot stop or start or stop in a particular moment of time. It has to be within their lifestyle. They have to control everything. And yeah, that's all I can say about the difference between these two. Otherwise, it's a human condition, it's a physiological effect that's going to happen. It's going to happen with most of the people.
Right. Thank you, Dr. Sabaz. Uh, Moving over, like you were just talking about, that this is what we can be doing at rural level, this is what we can be doing at urban level. My next question will be for Dr. Prakash. So, in your experience, how do you feel healthcare providers and communities can work together to improve arthritis care at the grassroots level?
So I'll take in the example of rheumatoid arthritis. Rheumatoid arthritis is very common form of arthritis. In rural areas, it is not picked up early. That is a problem. In at least in urban areas, they come to a orthopedician or a medicine doctor. They do the test. They take the proper history, and it is detected early. If rheumatoid arthritis is detected early, with the management of a rheumatologist or an orthopedician or even a simple medicine doctor, they can save their joints, multiple joints, and which we can delay the progress of the arthritis by very good effect. In rural areas, these are not picked up early because of the lack of the education, the lack of the facilities to get the things tested. So that is a very important thing that needs to be tackled. The rural population has to be educated regarding
Yes.
the type of arthritis, the medical treatment that can be taken in such conditions like rheumatoid arthritis and uric acid, the gouty arthritis, etc. And that will, I think, more than osteoarthritis, the other two, the things which can be corrected by largely by medicines, needs to be educated at the grassroots level in the rural areas.
Thank you, Dr. Prakash. Dr. Shabaz, please educate our audience about any governmental or non-governmental organization or a patient support group which is helping raise awareness about arthritis or providing support to arthritic patients that you're aware of, you're a part of, and you'd like to tell to our viewers here.
I'm not very focused on these. I don't know any NGO programs that is happening with arthritis. That's probably my ignorance. But there are sports organizations that I am associated with, and that is not related to arthritis. So arthritis as such, I do not, at least not in the Kerala sector, I do not know any segments that is dealing with this. There are NGOs. I'm told that there are a couple of NGOs that is working on these arthritis programs, but I'm not very well versed with that.
Okay.
I'm usually seeing patients through what do you call it? Elderly homes and old age homes and all that. They work on their independent levels, not as an organization, but through old age homes and all. They come and meet me, and then that is where I have the association. But that's not an organization as such.
Understood.
And
Understood.
Dr. Nishant, I'm really sorry. I think I have to go right now. I'm sorry.
All right, sir. Before you part away, any
Can I
one
leave?
last key take-home
I have
message that you'd like to give to all the viewers before we bid you bye, please, sir.
Yes, the main message I have to give these good audience of ours is: this is not a disease. This is this is something that we can uh, prevent or control. This is a part of our lifestyle, and this is inevitably going to come. But before it comes, we do not have to, prepone it. We can, even when it comes, we can control it. We can maintain our lifestyles. We can have, it is inevitably going to happen at some point of the age. I am also going to need a replacement surgery, but I can choose. I can, with my lifestyle and with my weight control and with my muscle training and all that, I can choose to have the surgery much later ahead of me. And once when I have that surgeries, it, my muscle tone and my, because I'm well trained, because I'm very cautious about my regular activities, I can use this implants to to continue my regular life, normal life, not to have a new life. Continue my new life in a regular pattern that I used to have. So start having your taking your lifestyle, your diet, your weight serious. Work out more. Eat when required, not because you are supposed, you can eat your food according to your flavors, you can enjoy, be foodie, enjoy your food and all that, but control your diet, control your intake, make it a habit to exercise regularly. Do yoga, do yoga, do yoga, muscle training. Keep yourself fit, not because you want to look good, but because you want to feel good. You want to it has a exercise has a lot of advantages. So focus on exercise, minimal diet, and that's my takeaway message.
Thank you, Dr. Shabaz. It was a pleasure hosting you here. You can log off now. Thank
Thank
you.
you, guys. It was a pleasure being here.
Yeah.
Thank you.
Thank you, sir. All right, Dr. Prakash, we'll continue the session with two more questions that I would want to ask. Very rightly summed up by Dr. Shabaz about the different messages that he would like to give to all the population. I would want to hear if there are any preventive measures that individuals can take to, let's say, reduce their risk of developing arthritis, or with patients to stop or maybe limit the progression of arthritis. I'm sure Dr. Shabaz mentioned a few, but I'd like a more summed up version from you. And towards the end, we'll then close this session. Please, Dr. Prakash.
So, prevention of arthritis starts with identifying what problem you have. If you have a knee pain, if it is bothering you, then go to a doctor, get it checked up, see what is the cause of the pain, rather than taking some pain medicines from the pharmacy or some local doctor. Go to a specialist, get your knees checked out. Is there any problem which can be dealt with early? For example, I will give you an example. You are a young man, you have had an injury, you have torn your ACL. It's very common. You are in college doing football, you tear your ACL. So ACL is normally surgery is done through keyhole surgery or an arthroscopic surgery. So if the ACL is not repaired at that stage, if you do the exercises and your lifestyle is modified, you can still get away with your knee without the surgery. But then the problem is that because of the micromotion between the upper and lower bones are increased because of the absence of ACL, that patient will develop early arthritis in the future.
Hmm.
So such things, early diagnosis, early treatment of things which are not directly arthritic at that point of time, but can lead to arthritis in the future, like rheumatoid arthritis, like gouty arthritis, like an ACL injury, like a meniscus tear. All these things has to be identified, diagnosed by a specialist, and taken care at that time when you are in your 20s, 30s, rather than waiting for your 50s and 60s to develop into arthritis. That is
Right.
one main thing I want to say. Second thing is, suppose if you have arthritis has been diagnosed, early arthritis, there are a lot of methods, lot of techniques, lot of medicines that can control at that point itself. So start taking care of your body, start your exercises, start your weight reduction. It is going to be a long journey. It is not going to be like 2 week therapy. Weight reduction will take years. So you have to be persistent at it. So contact your doctor, go to a specialist, get those things corrected. Suppose if your bend in the knee is more, at an early age, if we correct that bend, then we can offload the joint. We can prevent a surgery in the future. This is also a surgery, but you can keep your own knee for a longer period of time. That is called an high tibial osteotomy to correct the virus. So, thus that kind of surgeries which improve your alignment of the knee can be done when you are at earlier age. So those things can be done. When if you go to a doctor and he has identified that there are three compartments of your knee and only one compartment is completely worn off, at that time they can do a partial knee replacement. That means only the compartment which has been worn off can be replaced and an artificial joint can be put only in that compartment. So that will give you mobility, and also the other compartments are still your own compartments, your own bone. So you can get more life out of your own joint. So
Right.
such surgeries like partial knee replacement, unicondylar knee replacement, those can be done at an early stage if the patient presents to us. So go to a doctor, find out your condition and get that corrected. Suppose, okay, all this time you have not gone to the doctor, you have not taken your treatment seriously. Ultimately, you end up with a completely arthritic knee. There are treatment available at this point of time which can give you very good results. It's one of the most successful elective surgeries of orthopedics. Get the surgery done, claim back your life, get back your mobility, and enjoy life. Because we as human beings are mobile people, like Dr. said. So get back your mobility, get back your life, visit places, go to functions, visit your children, live
Right.
life. It is meant to be, not being crammed in your own room because of your knee pain. So get the treatment done, whatever it is, surgical, non-surgical, get it done at that point of time itself. That is my message.
Thank you, Dr. Prakash, for that beautiful message. And with this, I'd like to bring this particular panel of discussion to a closure. I'd like to thank Pfizer for powering this particular panel of discussion. And I'd like to thank my panelists, Dr. Prakash, Dr. Mohamed, Mohamed Shabaz, who were a part and took time out of your busy schedules to spread awareness along with Voice of Healthcare. So we thank you. And lastly, I'd like to thank all the viewers who have engaged with us and spent time in understanding the measures that we were discussing of. Thank you, Dr. Prakash. Have a good day.
Thank you. It's a pleasure working.